Good morning, everyone. Glad to have you with us on this sort of rainy morning. The webinar today is helping your clients manage their diabetes, lessons from the field. It's brought to you by the Maryland Department of Health. I am Sue Lockenmeyer. I'm your moderator for today, and I'm with the Living Well Center of Excellence. Our speakers today are Ms. Ellis-Marr, Ms. Haskin, Ms. Faith, and me, and I'll tell you more about each later in the presentation. I want to encourage you to put questions into the chat, right? Or yes, into the Q&A during the presentation. We will have plenty of time after the presentations, and you will be able to raise your hand as you go into the participant list, indicate that you have additional questions, and we can unmute your mic. In addition, we look forward to you sharing some of your own experiences. So let's get started. Our first speaker is Lisa Ellis-Marr. She is the project manager at the Maryland Department of Health, Center for Population Health Initiatives. She has more than 20 years of public and private sector work experience, and she's an accomplished manager of marketing campaigns and really in terms of building skills and problem solving. And I'm going to turn it over to you now, Lisa. Welcome. Please unmute your mic.
Good morning. I'm here representing the Maryland Department of Health, and we're happy to have you here. The Maryland Diabetes Action Plan intends to address diabetes across the risk continuum. If you could go to the next slide, please. As you can see here, we know that excess weight is a key factor associated with the progression of diabetes, and we can already identify people who are healthy and people who are at higher risk for developing diabetes because of their weight. Looking at this continuum, you can see that not only being at a healthy weight is no longer the norm. Only 32% of Maryland adults are at a healthy weight. That means 2/3 of the population are overweight or obese, giving them a greater risk for developing diabetes. Next slide, please. We are intending to implement the plan across the continuum. Working with the 3 buckets, we can change behaviors early by focusing some efforts on buckets 2 and 3, working in the community healthcare interventions and working with the healthy populations and reducing overweight and obesity and reducing risk with prediabetes and gestational diabetes. We can reduce the number of people that move into the first bucket managing their diabetes. Community health workers are a key part of this plan, working with people in all 3 buckets. Today, we're here to talk about the importance of behavior changes for people managing their diabetes. Next slide, please. This webinar will discuss the specifics of some of the key behavior changes necessary to live a healthy life with diabetes. Your role as community health workers is essential for people with diabetes to make these changes in their behavior. One critical thing community health workers can help their patients with is engagement, engaging them in their own health. This is why community health workers are so important. This is what you do best. Behavior change is not one size fits all. It's individual. An 11-year-old child with type 1 diabetes needs a different person to help them than a postpartum mother with gestational diabetes. And somebody who is 65 and developing type 2 diabetes needs somebody totally different. These are just three examples of individualized programs. There are many more. Doctors are going to refer the boy to someone that's fun and young and who can relate to him. And the same goes for the mother and the older adult. Community health workers can help each individual to become engaged in their health and help them with their own individual plans. Changing behavior is not something that happens overnight, but it's life-saving for people who do accomplish it. When you have diabetes, every day your blood sugar is well controlled is a day that you're not damaging other organs and systems in your body. Working with people to make these long-term changes is essential. Thank you for what you do, and for engaging your clients to take control of their health and being part of the team. I hope you enjoy the webinar today. Thank you.
Thank you so much, Lisa. That was a great opening, and welcome to everyone. I'm going to introduce our next speaker now. It's Ms. Danielle Haskin. She is a founder and senior advisor for It Looks Like Me, an organization that specializes in social and structural determinants of health. She is a community health worker and experienced in working with people who have diabetes. Danielle, I'm going to turn it over to you.
Good morning, everybody. Thank you again for having me today, and just really excited to hear the push behind community health workers. As a community health worker, even before realizing the term of community health worker, passion has really been health and advocacy for health of myself and for others. So I'll talk a little bit more about the role of community health workers in assisting with diabetes care. Next slide, please. So community health workers are you may be familiar with, but are known by many different names. So an outreach worker, a youth worker, a promotora de salud. You've likely heard some of these terms and didn't realize they were one and the same. So the definition, one of the many definitions of a community health worker is a frontline public health worker who is a trusted member of and has an unusually close understanding of the community service, the community that they're serving. The relationship of trust enables the community health worker to serve as a liaison between both the health and the social services that are available in that same community. That facilitates access to services and improves the quality and cultural competence of the service delivery. So that definition really encompasses what I believe to be one of the most important parts of community health workers and why they're so successful. What Ms. Mar just explained about the differences and the tailored approach really is, again, in my opinion, one of the greatest benefits of community health workers, because they're able to tailor that approach in a way that is relatable and understanding to each individual that they're working with. The community health worker also was able to build the individual and the community capacity by increasing the health knowledge of the people who they work with, self-sufficiency also through different activities, whether it be outreach, community education, some sort of informal counseling, and advocacy for their clients or the community that they're working with. Community health workers are able to provide local support to resources that are there in their communities, again, really bridging the gap between the resources who need participants and the participants who need those resources. Next slide, please. So an important part of diabetes and pre-diabetes care is self-management or individual behavior, as we heard. Community health workers have a general academic understanding of the role that healthy eating and exercise in relationship to diabetes, and they're able to communicate that role in a basic evidence-based lifestyle recommendations that we'll learn a little bit more about today from the following presenters. And the communities most affected by diabetes, community health workers can help them facilitate the development and the implementation of diabetes self-management, increase the potential for program success once they're in those programs, and assist with navigating the pathways towards reducing morbidity, mortality, and the incidence of new diabetes among the persons that they care about the most. Next slide, please. So there's some information on the disparities of diabetes, and you'll see on the graph on the left here just how drastic the disparities can be, or sorry, on the graphs on both on this page, just how drastic the disparities can be just between one group from another. The disparities that are related to diabetes in part are connected to access to care. So if you're living in a more rural area where you may not have access to primary care physicians, or even some of the diabetes self-management programs, um, can play a role, especially in many communities in racial or ethnic minority communities, excuse me. So using community health worker model to address disparities in access to diabetes education is a proven successful strategic and practical approach that has positive evidence to support the success of using community health workers. Individuals who serve as community health workers, again, can contribute to diabetes education, but also kind of reiterate some of the things that are learned in those programs, provide instruction, provide education themselves, often from personal experiences of going through some of the same situations. And teaching the self-management skills, assistance with group facilitation, and emotional support that's related to diabetes complications. Next slide, please. So some of the core skills of community health workers include basic assessment, goal setting, planning, implementation, and then monitoring and evaluation as we begin our path towards success. We're able to measure vital signs, do a basic literacy assessment to making sure that we're understanding the information that we receive as diabetics in a prevention program or a self-management program. Assessment can include family and social support systems. As we have heard, we'll hear that support is really an important part of health behavior change and managing our new lifestyles. Provide support, whether general information and guidance regarding access to care, what programs or educations are available, and also financial assistance in how to apply or seek out those different financial assistance programs. Community health workers may help with patients by providing basic information and assisting in setting basic goals for healthy eating habits or exercise routines, other appropriate physical activity as defined by the programs that we join. Also assistance with planning and following the prescriber's orders and the diabetes educators guides and guidance for implementing the plans of care once we have developed those plans. But also support diabetes management skill training and offer additional guidance on accessing care and financial resources. Really, again, because of the experience and the personal experience, they're able to help lead some of the support groups and organize the community as a whole in advocating around support or activities. And continuing to monitor and evaluate towards the plan, report the different findings, maybe the describer, so being the linkage between the direct healthcare provider and the patient. Next slide, please. So like many things, diabetes management is something that's most successfully approached from a team perspective with lots of support and encouragement. It takes care coordination between community members, community health workers, healthcare providers, along with an effective bidirectional referral system. The emergency room utilization can be reduced for preventable chronic diseases issues, specifically diabetes in this case. And helps to restore a sense of trust among program participants with the community. Community health workers should be used more inclusive as a part of the overall healthcare team. And the benefit also is cost effective, so they provide little to no cost to program participants for diabetes education and training program success. So there's a little information. Again, I'm really excited to hear the push and the outcry of benefits from community health workers and really providing support, education, and assistance with diabetes care management. We'll hear a little bit more about those specific programs further in the presentation. Thank you.
Danielle, thank you so much. Your experience as a community health worker, I think, makes a huge difference, and your being really in touch with things. Forgive me, my dog has decided he would like to share in how he appreciates the work that you're doing as well.
Thank
And
you.
I'd like now to introduce our next presenter, Sue Vaith. Again, has years of experience in aging and disabilities management and leadership. She is the diabetes coordinator at the Maryland Department of Health in the Center for Chronic Disease Prevention and Control, and really will speak more to the programs that Danielle was just talking about as well. Sue, I'll turn it over to you.
Thank you, Sue. You can go to the next slide. So our Center for Chronic Disease Prevention and Control is located in the Prevention and Health Promotion Administration of the Department of Health, and this is our vision and mission statement. Next slide, please. I'm going to talk about two programs today, one for diabetes prevention and the other for diabetes management, and how to find classes for each one. The National DPP, or the National Diabetes Prevention Program, helps people at risk of developing type 2 diabetes to prevent or delay it. And the diabetes self-management class is for people who already are diagnosed with diabetes. Next slide, please. Both of these programs are proven to help people maintain or improve their health status related to prevention and management of diabetes. The National Diabetes Prevention Program, or National DPP, is for people who don't have diabetes but are high risk for getting it. It's intended to help people with prediabetes or who are at risk to learn to take better care of themselves and to reduce the chances of developing type 2 diabetes. The Diabetes Self-Management Education and Supports Program is a program for people with type 1 or type 2 diabetes and is intended to help people learn to take better care of themselves and reduce their chance of developing diabetes-related complications such as eye, nerve, kidney damage, foot damage, cardiovascular disease. Next slide, please. So first I'm going to talk about diabetes prevention. The Diabetes Prevention Program is a year-long program for small groups of people who are at risk of developing type 2 diabetes. In these classes, people learn real changes such as healthier eating, adding physical activity to their daily lives, and improving problem-solving skills. Next slide, please. Research shows that the CDC recognized lifestyle change programs, or the Diabetes Prevention Program, participants who lost 5 to 7% of their body weight and added 150 minutes of exercise per week cut their risk of developing type 2 diabetes by up to 58%. And for older people or people over age 60, that raises to 71%. So even a decade later, program participants were 1/3 less likely to develop type 2 diabetes than individuals who did not join them. So that's a lot of diabetes complications avoided. The program can also lower a person's risk of having a heart attack or stroke and improve health, make people feel more energetic, and even reverse the prediabetes diagnosis. Next slide, please. All program participants must be 18 years of age or older at the time of enrollment, must be overweight or obese as measured by a body mass index of at least 25 or 23 if person is Asian or Asian American. And participants need to qualify based on either a recent, within about a year, blood glucose test that is higher than normal but not high enough to be diabetes, or have a history of gestational diabetes, or have screened positive on a diabetes risk test, or a prediabetes risk test. The participants may not have a previous diagnosis of diabetes prior to enrollment and may not be pregnant. Next slide, please. Every provider offering the program has been approved by the CDC. The National DPP uses an approved curriculum with lessons and handouts and other resources to help people make healthy changes. A lifestyle coach specially trained to lead the program will help participants learn new skills and encourage them to set and meet their goals and keep them motivated. The coach will also facilitate discussions and help make the program more fun and engaging. It takes place in groups so participants can give and receive support from each other, and they can share ideas, celebrate their successes, and work to overcome obstacles that they face. In some programs, the participants stay in touch with each other during the week, and it may be easier to make changes when working as a group than doing it on your own. I think a lot of people find that. The National DPP may be offered by in-person, online, or in some combination of that, which is especially important during COVID-19 emergency. A lot of the programs really pivoted quickly from providing in-person programs to distance learning programs using platforms like Zoom. The DPP is structured as a one-year program, as I said before, with weekly sessions for the first 16 weeks, and then moves to every other week or monthly for the rest of the year. A year might sound like a long commitment, but learning new habits and gaining new skills and building that confidence takes time. The DPP is covered by Medicare, and in Maryland is also covered through the Health Choice Medicaid managed care organizations. Next slide, please. The National DPP class focuses on healthy eating and adding regular physical activity to help with the goal of losing that 5% of body weight. And it also provides information and practice on dealing with stress, coping with challenges in life that might get in the way of making healthy changes, and how to get back on track if people stray from their plan. Some providers do grocery store tours and cooking demonstrations, so that's a lot of fun in those classes. And in the second half of classes, participants will enhance the skills they've learned so they can maintain those changes. Next slide, please. Ultimately, participants will learn how to create a healthier lifestyle to reduce the chance of developing type 2 diabetes by setting goals and using the tools they learn to eat more healthy and be physically active. Next slide, please. This is the pre-diabetes risk test that people can use to indicate their risk of developing type 2 diabetes. At the end of this slide, there is a link to that as well, which you'll receive. Next slide, please. This map illustrates where the National DPP programs are held within about a 10-mile radius, excuse me, or about a 15-minute drive time. Online and distance learning classes are also increasingly available. Next slide, please. In Maryland, there are currently about 61, 63, somewhat like that, programs offering the National DPP via in-person distance learning and online delivery methods. And providers are small community-based organizations, large hospital systems, local health departments, and other types of people like the YMCA or employers. The National DPP is covered, as I said, by Medicare, and for folks who are members of managed care organizations, it is also covered for them. Next slide, please. All right, so now I'm going to talk about the diabetes management for people already diagnosed with diabetes. Diabetes Self-Management Education and Supports, or DSMES, is a 10-hour program for small groups of people with diabetes, and it's been proven to help people learn how to manage their diabetes through the course of the disease and to help prevent or delay complications. Next slide, please. There's a lot of evidence that links participation in a DSMES class to positive changes in health behaviors and improved diabetes-related outcomes. These include improving glucose levels, improved blood pressure control, and cholesterol levels, higher rates of medication adherence, fewer or less severe diabetes-related complications, healthier lifestyles such as better nutrition, increased physical activity, and use of primary care and preventive services, enhanced confidence to handle the disease, and decreased healthcare costs, including fewer hospital admissions and fewer readmissions. Next slide. DSMES providers go through a rigorous accrediting process and have an approved curriculum with lessons and other resources to help people make healthy changes. Eligible participants have type 1 or type 2 diabetes, and they can also be family members, so they can also support the folks. DSMES is a 10-hour program facilitated by diabetes educators, nurses, or pharmacists, and may be delivered as a group and can also be delivered individually if that is what's needed by the individual. Most insurance plans cover, including Medicare, cover up to 10 hours of diabetes education the first year of diagnosis. After the first year, the coverage may be different, and people should contact their insurance companies to find out more. It is not, unfortunately, covered by Medicaid. Next slide, please. When a person is first diagnosed with diabetes, it's confusing to know what they need to do. The DSMES helps participants learn how to make the best decisions for them. And they should ask their doctor for a referral to DSMES as a referral is required. In the class, participants learn how to stay healthy and how to make what they learn a regular part of their life. So it includes working with their healthcare team to get the support that they need, understanding how to take care of themselves, to learn the skills to eat healthy and be active, checking their blood sugar levels, solving problems, taking medication, coping with the emotional side of diabetes, and reducing the risk of other health problems. Next slide, please. It's important to go for DSMES services when a person first finds out they have diabetes so they can learn how to take care of themselves. And there are other times DSMES can help too. So annually, people should check in with their doctor when they have a visit, when new situations occur, such as developing a new health condition, or if they have depression, which is common for people with diabetes, and when other changes happen that might affect their diabetes. Next slide, please. This map shows the location of DSMES program providers. DSMES programs may now offer, before COVID, only a few rural organizations were allowed to provide the classes via telehealth, but in the national emergency, all providers are allowed to use telehealth, and we're actually hoping that that continues after the public emergency is over. Next slide, please. In Maryland, there are currently 38 programs offering DSMES at 52 locations. Delivery methods are usually in person, but as I said, during the pandemic, CMS has allowed providers to offer the program doing distance learning. Most providers are hospital-based or wellness organizations, and there are a few in pharmacies. DSMES is covered by Medicare, as I said. It's known as DSMT, and by other providers. So I'd also like to mention that the Department of Health is working not only to support current providers, but to build a strong network of programs so that it's more widely available and accessible. Next slide, please. Next slide, too. There are several ways a person can find and or be referred to the National DPP and to DSMES. Our office maintains a customized website called BeHealthyMaryland.org, where program providers may advertise their classes. And people can use the site to find classes, and you can also help your folks, your clients, use the site to find classes or refer and self-refer. Community health workers can refer patients through this online portal via secure fax. And if you can't find a class, there are a list of providers in your area, and that you can contact them directly to find out when the next class is. The American Medical Association and the CDC created a toolkit for healthcare providers and patients called Prevent Diabetes Stat. And the toolkit will guide healthcare providers through screening, testing, referring to a diabetes prevention program. And that tool also includes a link to find nearby programs. And that is something that community health workers might be able to use as well. Many program providers partner with healthcare practices to receive referrals and provide feedback about their referral and patient progress. Healthcare providers can contact program providers if they wish, and this goes the same for community health workers. You can contact providers and see about setting up a referral path for both diabetes prevention and or management. And the same arrangement, as I said, could work with community health workers and partnering to make referrals for their clientele. People should also ask or may also ask their doctor for a referral to DSMES. They may self-refer to the National Diabetes Prevention Program class. And if the person is a Medicaid MCO member, they can ask their MCO to connect them with a provider. And finally, your organization may consider becoming a diabetes prevention program provider and offering the classes in your space, or offering the classes in the space where you work. And at the end of this, there are some resources that you can take a look at, and I'll go through those in a moment. This is a screenshot of our website, BeHealthyMaryland.com, where you can find classes and contacts for the National DPP and for DSMES. Next slide, please. Sorry about that. That's the screenshot of the landing page. Next slide, please. And you can search for these classes as well as other programs that might be of interest. And Sue Leckenmeyer is going to talk about some other programs which can also be found on the Be Healthy Maryland site. Next slide, please. And all of these resources will assist community health workers to develop patients or clients, prevent type 2 diabetes and or manage their diabetes. You and your care teams will be able to use information to screen and refer patients and to these two important community resources. And I am available for questions when we are done. Thank you so much for your time and attention. Very happy to be able to talk about these two programs.
Sue, thank you so much. That's absolutely wonderful. We really appreciate your sharing this information with us. Again, we work together, and I think this is just a really great example of that. These programs really will make a difference. And for those of you who are community health workers, honestly, this is exactly the kind of program that you all can be trained to deliver, as well as whether you do it one-on-one or do it, with a group, and as well as the other services that you're providing in the community. So we're going to go ahead to look at the next set of slides. As I said, I am the state program coordinator for the Maryland Living Well Center of Excellence. I'm a trainer for a lot of the self-management programs. And, we look forward to, in fact, I recognize several of the names of folks who are joining us today for some of the other programs that we've done training for. In addition to the diabetes program, there's a chronic disease, chronic pain, the cancer self-management program. We have a number of exercise and falls prevention programs. And then a number of you have already been trained in PEARLS, which is a program to reduce depression. We certainly know that the likelihood of someone who has a chronic disease, particularly diabetes, is also often at risk for depression as well. And then we do have caregiver and malnutrition risk programs as well. So go ahead to the next slide, please. This is just an array of a number of the programs that we have here in the state of Maryland. And again, the wonderful thing about all of the programs you see up here is that they really are designed to be delivered by people in the community. We know that as community health workers, you are familiar with the community. You're familiar with the people who are there, and you are able to make really important connections. So your power as a leader or facilitator is greatly increased because you're a trusted member of the community. Next slide. So why do these programs work? It's really a principle that underlies them that says that whether you have diabetes or prediabetes or other chronic conditions, you will have similar concerns and problems. And in fact, when we have a chronic condition like diabetes, we're ending up dealing not only with the disease, but also the impact that it has on our lives, our emotions. And people with diabetes and prediabetes are more likely to, as I said earlier, identify with and trust leaders who've had similar experiences. Family members and caregivers can be active participants. That's one difference between some of the other programs that Sue Vaith was talking about. Here, as long as an individual is over 18, and they're a family member or a caregiver, they're welcome to participate in the program as well. And if many of you attended our first webinar with community health workers, we really talked about the importance and value of family and having a support system around you. Next slide. So Sue's already mentioned the Be Healthy Living Well site, and also our website, Maryland Living Well. The programs are accessible. So both of those places have them. And if you would like to become a leader or a counselor in some of these programs, again, you can contact us. This is Wendy Farthing's address and phone number here, but she is the one that organizes a lot of the trainings. We have been limited in the amount of work that we could do in terms of training until very recently. We were not allowed to do trainings other than in person, in group settings, but we have now 4 people who are being trained as master trainers who can deliver leader trainings, what we call leader or facilitator trainings, virtually. So we anticipate probably not until November, but November, December, we will be doing a lot of trainings virtually. As you all know, it's difficult to do a training in person right now for people. So that's one thing to look forward to. And of course, you'll have my information as well, so you can reach out to me. Next slide. So just quickly to better understand sort of how these programs work, as I said, they're open to all individuals over 18 and to caregivers. They're 6 weeks. We usually do a session, what we call a session 0 first. That allows us really to do sometimes the paperwork and to give people just a little flavor of what the workshop is like. Again, they're about 2.5 hours and they're highly interactive. It really is designed for the group of people who are attending to become the problem solvers, to become the supporters of others, right? And sharing their ideas of what's worked, that kind of thing. So it is facilitated by 2 trained leaders. They can be health professionals, but we tell people to take that hat off when they are dealing in the workshop, because it's really around facilitating that group to be able to deliver the workshop. The materials are standardized. They're the same all across the nation, and in fact, the world. Many of these programs are worldwide. They're highly scripted so that we know that they're maintain the fidelity to the original program and the outcomes that we can expect. They're very generally free. Some may be at low cost, but in general, they're free to participants. And it really is about participants becoming active in managing their care. It does not replace any other existing programs or treatments. So it really is meant as a support. Next slide. So the goals of a diabetes self-management program are really for an individual to accept responsibility to manage or co-manage their own diabetes, to become an active participant in a system of coordinated healthcare and intervention and communication. In fact, one of the big pieces around in the program is learning to communicate more effectively with your healthcare provider, but also with your family and friends. And then finally, to gain confidence to be able to perform tasks and to be able to really focus on your own health and make those changes that you need to do. And then also making sure that you're accessing that array of important services regularly. Next slide. So here are really the primary activities that go on almost every week through the 6-week program. Again, the self-management strategies are around decision-making, problem-solving, action planning, and then always urging and increasing physical activity. It's so important, right? Some of the topics covered: what is diabetes, and monitoring, a healthy eating plan. That includes a lot of work around label reading and learning about what should be eaten at what time, etc. How to prevent low blood sugar, which is something we don't think about often because we're concerned about it being too high. But it's terribly important to make sure that we don't get too low in the blood sugar. And then series on preventing or delaying complications and making sure that you have everything you need for sick days, and the importance of foot care. So again, a wide array of services, of topics, and the opportunity for people who are together in the workshop to share their experiences and how they problem solve around some of their situation. Next slide. So this is a toolbox. We have a toolbox in all of the self-management programs, and you can see some of the things. Obviously, we're just on that previous slide, but a lot of the tools that we would be using if we were being actively involved in managing our diabetes. Obviously, we already talked about healthy eating and physical activity, that monitoring piece, stress management, understanding emotions. Those are things, and using your mind, those are things that of course apply to all of us regardless of our condition, right? Really important. That communication piece that I spoke about, things around not smoking and how to really take charge if you are smoking. And again, that problem solving, and then working with your health professionals as a member of the team, an active member of your own team. Next slide. So I did want to highlight some of the other resources that community health workers hopefully know about. One of your partners should really be your local area agency on aging. The resources include nutritional counseling and education, can include the meal programs that can be home delivered or in congregate meals, not right now, unfortunately, but generally. And then nutritional supplements, things like that, that can be accessed through the AAAs. Financial support for those clients of yours, so that could include SNAP, Medicaid, then SHIP, which is this State Health Improvement Program, and then energy assistance programs, income tax assistance, Medicare prescriptions, Part B premiums, medication and supplemental grants. Those are things that are really a part of the daily work of the Area Agency on Aging. So when you have a client that may need some of those services, that might be a good place to turn to. And then we do have a number of in-home things, our senior care workers in terms of a sitters list, assisted living subsidies for folks, telephone reassurance and options counseling. Again, that medication management piece, often we are able to, at a AAA, provide or connect people with assistance for dental and eye care and hearing aids. And then that social support, which is so important. We know we're all missing it now, the support groups, the senior centers, volunteer opportunities. Hopefully those will come back in the near future. And certainly a lot of it, the work that we're doing now is telephonic or telehealth. And then environmental assistance. So people may need additional resources in terms of their technology equipment at home or modifications that might be needed for safety. And then finally, those health and wellness programs. That was on that first slide that I showed you, the various programs that we know help people make meaningful, long-lasting behavior changes. Next slide. And I did want to share with you one of the pieces that we are moving forward with now. We're really excited about this. During COVID, we really realized, particularly in our rural areas and in low income areas, people do not have the connectivity that they need. And I know a number of you are already introduced to and using a lot of the tablets where you can intake information and see a client virtually. We are really working closely with Eagle Force, which is an IT platform, to load tablets that could be loaned out to individuals as well, so that you might be able to have that opportunity when you're delivering service to actually see them and see their house, as opposed to, or their living quarters, as opposed to just telephone services. So more is coming on that. We are excited about it and beginning to pilot it this week on the Lower Shore, and think it will be a real opportunity for people to be able to provide connectivity to people who don't have it right now. Next slide. So this is sort of what it looks like. It's a tablet or a phone. It can be, again, a couple of different providers. We know a lot of folks use Verizon, some use T-Mobile. So we have that flexibility to be able to connect it. It has, in addition to being able to do the telehealth that people might need, and your opportunity to interact with them in a virtual setting for workshops, something like that, and other services. It will provide unlimited talk, text, and data for them to access during the time that they have the tablets. Our plan is to really loan them for a period of time. These tablets, however, can also be ordered by a provider and can be reimbursed through that provider, that healthcare provider. So as you identify folks in community that may need additional connectivity, that's an important thing to be able to bring back to your organization and for all of us to work together to really access some of that information for them. Next slide. That's it. So I want to encourage you, please, to go to the participant area, click on your name, raise your hand so that we can unmute your mics. Oh no, we're not doing that yet. Danielle, you're supposed to be on, I forgot. So look, I'm gonna put Danielle back on and we're gonna really open it up. Primarily, she wants to share with you and have your input into problems and challenges of really problem solving around a lot of the things that are going on in community with cases that you've got, that kind of opportunity and option. So we'll do that and then do other questions moving forward. Danielle, I'll turn it over to you.
Thank you, Sue. So I'd really like to highlight that slide that you had, the AAA resources. Because as community health workers, we know that while we're focusing on maybe one condition, such as diabetes, without addressing the other elephants in the room, whether it be educational support, financial support, you had the resources on energy assistance and nutritional support. You know, where am I going to get dinner from? I really can't focus on managing my diabetes. So some statistics I just looked up. We have about 1 in 5 non-elderly adults with diabetes diagnosed reported not taking their medication as a result to cost. That's compared to about 1 in 10 adults without diabetes diagnosis. And out of those with diagnosed diabetes, of adults, that is, adults that have an income below $50,000 per year or more than twice as likely to report not taking medications as prescribed due to cost. And we know how important managing our diabetes is in relation to other chronic conditions and just in our overall health. Diabetes is commonly treated with medication. So making sure that we can afford our medication and we know where to go for resources if we can't is really important. According to the CDC, most adults with diabetes diagnosis use either insulin or pills for diabetes management, about 81%. That was. Going along with the information you had on resources, advocacy for patients with diabetes is immensely important. If we don't have some of the programs that we learned about today, advocating to get some of the programs to see where they're available virtually. As we learned that there were additional resources, I'm always learning and taking notes. So the information on connectivity and how can we provide resources for people who may not be able to take advantage of even the new virtual resources that we have. So advocacy defined as active support and engagement to advance a cause or policy. It's really needed to improve the lives of patients that are at risk or who have been diagnosed with diabetes. Given the tremendous toll that obesity, physical inactivity, other things like smoking have on the health of patients with diabetes, we really need to focus on and address change in the social determinants at the root cause of these problems. I'd just like to share a story of that happened actually just this past summer, where I was working with a local nonprofit and we were doing food deliveries or emergency food resource distribution. And it came up that maybe some chronic conditions were going unaddressed with the concerns of the pandemic and going to the hospital. So I set up a table and I was doing blood sugar readings and blood pressure readings. And a young lady came up and she would come up, I was there once a week, so she would come up and she'd have her blood sugar checked and her blood pressure checked. And I think it was the second or third time she mentioned that she's new to the area and she just moved from New York for a job here in Maryland. And was working only a couple weeks and then was laid off. So she didn't have insurance. She no longer had a job. She was coming for food assistance. And just the idea was preventative care, but she explained to me that she was diagnosed with diabetes and she was running low on her medication. So I was able to connect her to the local federally qualified healthcare center where she was able to go through the assessment, get her medication, and continue on. She was down. What I didn't know was that when she first came to me, she had taken her last metformin, her last pill. So the importance of just being in the community, again, is just kind of something I wanted to share of the benefits of us being in the community, having those conversations. She wasn't familiar. She didn't have any family or friends here. Her family didn't really speak English. English wasn't her first language. They didn't speak English very well. And she was a little bit ashamed and shy to mention this. But just by being available and knowing the resources, and even if I didn't, if you don't know where to go, we know who to ask. And I think that's another important part I'd like you to take away from this. Just sharing the stories that we have, and sometimes the most powerful thing that we have are our stories, because it helps people to relate to something maybe in the future, and to understand that what they're doing is important, and to share your experiences.
Danielle, that's really wonderful. Thank you so much for sharing that. And there is actually a question here about what are the options if a client has no insurance. I think that's partially what you were describing. And we may be able to answer more of that with Dr. Sadie Peters moving forward once we've finished this part of it. I just wanted to check with you, Danielle, did you have anything else you wanted to add?
No, that was actually it. Thank you.
Okay, wonderful, wonderful. So what I'd like to do now, first of all, I do want to remind you that there will be a post survey. We do want you to take that after the end of the session. And it's really important to us to learn what's been helpful to you, what's missing, what you still need. We plan to be working on reducing diabetes across the next 5 years, and I'm sure beyond that, but hopefully really to begin to make a significant difference in the health of our population. So please be aware of that and be honest with things that you see that are missing. In addition, I wanted to let you know, in case you're not aware, that we have actually a total of 8 webinars that we've been doing through the month of September. And while we have targeted 2 of them specifically to community health workers and direct care providers, there are a number of other ones that you might be interested in attending. There are 3 clinical ones. They all are titled so you can see what would be of interest to you. And then there are 3 that have been directed to people with prediabetes, diabetes, and their family members. Again, extremely helpful information. We are a little more than halfway through, so many of them are already finished, but they are recorded, and you can access any of them and be able to get a certificate of completion for attending those recorded webinars, as long as you, again, complete the post survey at the end. So feel free to share that with family members, with friends, and if you've missed some of the series, we would love for you to go ahead and take advantage of that. All right, so I'm going to actually ask Dr. Peters and the panelists if you would open your mics and your videos and feel free, please, to add to the discussion. But then I'm also encouraging all of you who are participating today to go into the Q&A, or into participants, and click on your name. That will raise your hand and we will allow you to talk. We do want to hear from you, both your successes and some of the challenges that you've had in the field.
So I can start to answer the question that was asked about what if people don't have insurance. The diabetes self-management education program providers, many of them do rely on insurance, but many of them also have scholarship programs. And for the National Diabetes Prevention Program, that is only newly covered, and not every provider actually is a member of Medicare and Medicaid to be able to get reimbursement for those. So they often continue to offer those at no or low cost. So my recommendation is to call the provider and ask them what the cost of their program is, or you tell them that you don't have insurance and ask if they have scholarships. And that will most likely get you an entree into the program.
That's great. And again, all of the programs, the self-management programs that I highlighted are available at no cost. So that's helpful. But again, I think if someone does not have insurance, the other important piece is we do want to make sure that that individual is connected to other resources so that they can access medications and physicians as needed. So Lisa and Danielle and Dr. Peters, love to have you open your mics and videos and add to the discussion. And all of you who are attending, we would love to hear from you as well.
My mic is open. I'm unable to start the video. I think somebody on the IT side might need to do that.
Just to add to
There you
what
go,
Ms.
just like magic. Yep, there you go. We'll get you all up.
Perfect. Just to add what Ms. Vaith mentioned, getting the information on, talking with your providers, but also potentially talking with your local health department, your hospital. They may have community health workers on staff and connecting, but it's important to continue on our healthcare path that we do have some sort of a primary care provider or a medical home. So while we may not have patients or clients with it who have insurance, but addressing that again at the root cause and looking into, do they qualify for healthcare connection, and speaking with somebody who may help them go through the application process to obtain insurance.
Great, great. And there was another question in the Q&A that said, how do you get a patient to receive a tablet with a free data? So the tablets themselves can be ordered by a primary care provider. In terms of the way that we're working with it, and we did do a presentation for Maryland Primary Care Program indicating that these tablets could be available to providers for their clients through EagleForce. That is not the only place where tablets can be ordered, though, for individuals. And in terms of telehealth now, under COVID, there really are some reimbursement codes that allow physicians much more opportunity for connectivity.
This is Dr. Peters. I'm always really pleased to be listening to all of the presentations because I do learn something new every single time, and sometimes a lot. One of the things that I wanted to circle back and emphasize what both Lisa Marr started out with and what Danielle just highlighted is that having someone who is either at risk for diabetes and who may have a diagnosis of prediabetes, or someone who has diabetes already, getting that person to the end of their life, however long that may be, and we hope it's a long life, but getting that person to the end of their life in good health really does rely on engaging that person in their care. And of course, there are a million competing risks, job loss, housing, raising families, taking care of older parents, cars that break down, terrible bosses. There's a whole host of things that, make it really hard to maintain self-care. But having people be as knowledgeable as they possibly can about their own health and as engaged in helping to take care of themselves as they can possibly be really is the key. How do you do that? Most of us live out in the community. We don't live in the clinics where we can have the nurse, the doctor, the medical assistant, the social worker who is in the clinic help us with all of the things that we need. So community health workers, social workers who work for organizations, community-based organizations, they all can have those multiple touches so that patients can have many points in their lives in which they are engaged with people who are able to help them. I just feel like that's a really important thing, that keeping people engaged in their care and not letting them sort of be out in the world by themselves without help is super important in helping to have good outcomes for health. The other thing I wanted to emphasize that I think was not maybe as concrete as it might have been is that for anybody with a diagnosis of diabetes, we really do want you to, everybody who has diabetes should have DSMES, which Sue Vaith talked about so well. Everybody who has a diagnosis of diabetes should have DSMES. Currently, only about 6% of people who have a diagnosis of diabetes get DSMES in that first year after their diagnosis, and that's terrible. Clinical providers are not referring as often as they should, and clients aren't going. Somehow there are many barriers and many gaps, and there's lots of research being done right now to figure out why that's the case. But the DSMES is a lovely, intensive education for patients who are newly diagnosed, but not just newly diagnosed, but you can get that information and that training at various points throughout the life of the patient. So that's an important part that we need to encourage more patients who are diagnosed with diabetes to actually use that service. And then once that's done, the next step would be all of the programs that Sue Lachenmeyer and others have discussed, is getting that sort of peer support throughout your life in the community with diabetes self-management programs, chronic disease self-management programs, and all the other evidence-based programs that are available in the community. But everyone who's newly diagnosed should get DSMES and then should get it periodically and then get further support with all of the community-based programs. I just really wanted to emphasize that point.
That's great. That's great, Dr. Peters. So I have another question in the Q&A, and that is the tablet only for those with diabetes? No, the tablets really are designed for underserved, unconnected individuals who have chronic conditions in general, and that's a very broad, again, the opening up of telehealth and utilization of IT under COVID will not go away. We're sure that now that it's being embedded, there will be more and more pressure to make sure that people have that accessibility. So it would be anyone with a chronic condition that was in need of IT connectivity. And I'm just trying to think, I recognize some of the names of folks who are on today, and I'm wondering if I can start opening. We would love to hear from you. I mean, the previous time that we met with community health workers, we had really a good dialogue and interaction with sharing from individuals. The same has been true, by the way, for sure, of our webinars that have been with people who have diabetes or pre-diabetes. They've been very open and willing to share their frustrations, their challenges, and what would be helpful to them. And I do want to let you know that on the 30th at, I'm trying to think, 11 o'clock, from 11 to 12:30, that is a webinar that is really for individuals with diabetes. But the information that's being shared there is going to, again, go over some of these other resources that can be accessed through local public health departments, more information on the tablets and how they could be utilized, as well as other important information from Dr. Singh, who will be sharing information about managing diabetes. So you more than welcome, and we encourage you to utilize some of these other programs as well. I'm just not seeing questions from you all. Will, I may have to call on you and ask you if you would like to share some of your experiences in being a community health worker.
So there is a question about recommendations for clients who won't manage their conditions or situations.
Oh, good. You know what? I'm sorry. I didn't click all the way down. That's a wonderful one. And Dr. Peters, we may turn that one over to you and to Danielle both.
Sure, I can start with that, and I'm sure Danielle has things that she can recommend as well. You know, and Sue actually also, both Sues could also speak to this. There are lots of reasons why clients won't or can't manage their conditions or situations, and it's important to find out what those reasons are. So motivational interviewing and trying to understand what the barriers might be. And it's possible that the client may not truly have identified the 1 or 2 or 50 reasons why they're not managing their condition. So it's really important to try to talk and then to talk to say that you're interested to hear why, and then really listen. Because it may be that, you know, their son was just diagnosed with cancer and is dying, and that makes thinking about your own problems and your own diabetes makes it a lot harder because you're so worried about your son who's dying. So there are lots of different, and it might not be the right time to focus on adding a new medication for the diabetes. But again, that's something that if you can listen to find out what the problems are, then you might be able to help. So yeah, and I know far less about this type of motivational interviewing than many of you on the call, so I will stop there.
Danielle, go ahead. Or Lisa, did you want to have something to say?
No, there's another question. I was just looking
Okay.
to make sure we get it.
Okay. Go ahead and ask the question. That's great.
Well, does Danielle have more to say on that topic?
Yeah, I don't think I could have said it better.
Oh.
Just really being in tune with Dr. Peters, really being in tune and realizing that I'm sure as all of us, there's so much going on at any given time. And is it, are there other family member health concerns? Are there child care concerns? Are there financial concerns? So addressing some of the other just life situations. It may not be that they don't want to manage, but that they just really can't manage. Sometimes it's nothing that's visible. It's something you may not see, but it could be it's mental health and our emotional health, and really having a conversation and just talking to find those root causes.
Yeah, and just if I can just add to that, I think it's easy to blame the person who has diabetes and call them non-compliant. But I think turning that on its head with exactly what Danielle and Dr. Peters are saying is looking further into what could be the root cause rather than, oh, this person's not compliant, I'm going to write them off.
Right, right. I'm going to actually open up the mic for, if I can do that, let me see here, for Matthew Bergen, who indicated that he would be happy to share some of his experiences as a paramedic. And now I've lost his name over here. Here we go, Bergen, there we go. I'm hoping that I can open your mic. Let's see if that's working. There we go.
Well,
Matthew.
good morning. I appreciate you letting me speak a little bit. I am a community paramedic in Frederick County, Maryland. We are one of 11 programs across the state that is using EMS providers, specifically paramedics, in a little bit expanded role from what we're typically used to doing, where we look to apply the the principles of fire prevention to EMS and identifying that we can do a better job as clinicians if we prevent the problem than we do trying to respond to it. So the initiative started in Queen Anne's County over on the shore back in 2014. Frederick County's program came online in 2018, and we've been doing some pretty cool things ever since. We work very closely, so we're a mobile integrated healthcare program. So we work very closely with our hospital partners, Frederick Health and Frederick Health Hospital, the Care Transitions organization that works there as well. We have a very good relationship with our area aging agency, our senior services division in Frederick County that administers our MAP program. We also work very closely with our AIRS folks in the health department and a lot of other really crucial community support and organizations. So earlier on, it was mentioned about the social determinants, and that's huge. When we look at, our programs were launched to address disproportionate utilization. I'm not a fan of the word high utilizer. Everybody utilizes EMS and utilizes healthcare to the level that they feel is appropriate for them. What we know as clinicians in the healthcare setting is that sometimes that utilization is disproportionate. And when we look at the reasons why, a lot of those reasons are seated in the various social determinants of health, or what we call the individual barriers to self-management. So when I go out as a community paramedic, I'm not so much focused on the clinical side of things, although that certainly plays an important role. But what I'm looking to find out is what barriers exist in your life, in your day-to-day operations, that prevent you from being able to manage yourself to a level where you wouldn't need to depend on healthcare. And when we identify what those barriers are, we can help put the proper resources in place through our partnerships with our hospital and our care organizations. The motivational interviewing technique that was mentioned a few minutes ago is critical, and being able to help folks identify a problem that maybe they don't even realize exists, and then fixing out without them necessarily even realizing that you're fixing it. So, it's pretty cool to see that a lot of the tools that we're using in our program that we thought, we were doing a pretty good job with are also being used with a lot of success, across the healthcare landscape. So I appreciate getting the chance to sit in and listen with you guys, and hopefully, some of our experiences will help kind of open the door for other folks.
Thank you, Matthew. You really managed to describe what's really necessary. I really appreciate that. And I'm going to now turn it over to William. There you go. You're on. I'm sorry to put you on the spot, but I know that you are deeply involved and have wonderful experience in community. Sounds like he's got a phone call.
I'm sorry. Sure. Can you hear me?
Yes, we can hear you.
Good morning. I had a call coming through while this was going on. First and foremost, I want to say thank you for providing the training. Very informational, very well needed. And like the gentleman before me just said, just understanding the populations that we serve and the social determinants of health that impact those populations. There's so many underlying things, whereas they're having barriers and challenges to accessing treatment and understanding the language that the provider is speaking. So the community health workers are very essential part of this equation, because basically what they do is they bridge the gap between the provider and the patient. So just getting to understand the populations and being able to translate and providing authentic non-judgmental engagement is very important.
That's great, Will. Yeah, and I think one of the things, Will has just recently been trained in the PEARLS program, which is the depression reduction program. And I think Danielle and others mentioned it. And indeed, if someone has other issues their diabetes may not be foremost in their mind. And so those opportunities through motivational interviewing, but also assisting someone in really making those changes that they can better manage their depression as well can be huge in really changing their ability to be more attentive to their diabetes needs, for sure.
Absolutely.
And yeah, thank you so much, Will.
Thank
And I do have a question here about resources that would be available to individuals who may not be computer literate in terms of that MimiRx tablet. And again, I will just let you know that there is an opportunity for individuals to, the actual IT platform is forward facing, so the rights to access are owned by the individual who signs up for the program. So it would be an opportunity, I think, to be able to do that. And I may need Sean to get connected with you better. I know, again, that the program on the 30th is going to speak in more detail for individuals who may not have accessibility. And I can ask our speaker to provide some specific information on how people could, on their own or with your assistance, connect to Eagle Force, which is the one that has the tablet, and to make their case and potentially be connected. So I'm happy to do that, but it probably won't be until that particular webinar. Lisa, did we cover the question that
So there's one more.
Okay.
It says, are these programs available in other languages like Spanish or for the deaf?
Oh, good. Thanks very much for asking that question. We do have Spanish capacity, not every county, but we certainly do. And the fact that we are doing programs virtually, I can tell you that Anne Arundel County is running a number of diabetes programs. Again, it would be on the Be Healthy website. And what you would look for would be virtual programs. Again, or it's hard to connect with all of you. I'll have to think about putting my email someplace that you have it. I can actually, I'll try to put it on something after the webinar. But again, there are definitely opportunities there. We have the programs to some extent. It's much more difficult because we're in a virtual environment, but we have certainly a wide array of speakers of Chinese, Korean, some of the Asian Indian languages. In particular, I don't know, and those are the ones that come to mind for sure, that we have people with the ability to deliver the program. Spanish, definitely, though.
And for diabetes self-management, education, and supports, the DSMES and the National DPP, it's not as available, certainly, as we would like it to be in Spanish, or even for people who are deaf. But my recommendation is, if we're always looking to have the providers partner with organizations that serve people who speak other languages, or people with disabilities, people who are deaf or hard of hearing. And so that they, with their expertise, can become trained and teach these classes. That's particularly for the National DPP. It's a little bit more difficult with a DSMES because only specific providers can do that. But again, I mean, it's a question of calling the individual provider that's close to you and find out what they offer in terms of providing classes to deaf and hard of hearing, or to people in Spanish.
And I can, if you've got a pen and paper, I can give you my email address now. It is B as in boy, S as in Sam, LACH @earthlink.net. So if you have questions or concerns, you absolutely can reach out to me directly, and we'll get you the answers. I will remind you that this webinar is being recorded, as all the others. Please feel free to let others know about it. And please, at the end, do fill out that post-survey and evaluation to let us know what else you all need. You really are critical in terms of delivering important resources and care to individuals and communities. So we really want to be very attentive to the needs that you all have in the field. Any other questions or concerns, input from our wonderful panel today?
I'm going to type Sue's email address into the answer for the question so everybody can see it. And so if they didn't get a chance to write it down.
Thanks, Lisa. Put mine in, not yours.
Yep. I'll also include mine too in case you have questions for us.
You know, if I can't answer it, I'll forward it to you anyway. So between you and Sue Vaith, this is really a team. And I have to just say, I treasure this opportunity. We've had a wonderful time doing these webinars, and we're so grateful to all of you for participating with us today. Take care, everyone. Have
Thanks,
a good rest
everyone.
of your day.
Thank you for having us. Bye.
Thank you.
Bye-bye.